Hello, my name is Andrew Lim, and today I'm going to be discussing my plans for improving patient outcomes, increasing patient satisfaction goals, while also decreasing lengths of stay and decreasing complications for the patients in the inpatient critical care, intensive care environment. For those of you who aren't familiar with reimbursement of hospitals for patients, um, these are the four factors I've listed are major components. Um, Medical diagnoses receive a certain amount of days per diagnosis, and once a patient extends their stay past this diagnoses and/or they develop a complication, the hospitals get a reduced reimbursement rate, or if none at all. The way that I plan to combat some of these issues, which are major in hospitals these days, is the early mobilization of patients in the critical care, intensive care environment. While mobilizing patients is nothing new to a hospital setting, um, surgeons have long known that early mobilization will get their patients out of the hospital faster and reduce recovery time. The critical care setting is much different. Patients who are admitted into the critical care environment obviously have a reason, and many aren't unable to participate in these mobilization techniques initially. And that's kind of where the problem lays in the critical care environment. We have a mentality that the patients in critical care should stay in bed because they're too sick until they are able to get better and rehabilitate on a medical surgical floor or rehabilitation specialized center. Uh, there's a paradox that Dr. Robert Stevens from Johns Hopkins states that patients, that physicians who admit patients to critical care want them to stay in bed and rest so that they can become well again. But when those same patients rest and stay in bed, they develop muscle weakness and muscle atrophy, and those patients are known to do much worse in the critical care environment. Other complications for not mobilizing patients include, like I said, deconditioning, pressure ulcers, and hospital-acquired infections such as pneumonia. There are also psychological effects for patients and their family members when they see that their their family member has been laying in the bed for several days, maybe even several weeks, and hasn't gotten up when previously they were able to move around at home and do everything for themselves. So my plan is to develop a multidisciplinary unit-based team, which includes the medical doctors, registered nurses, respiratory therapists, and physical therapists, as all of them will be working side by side in increasing mobilization for these patients. Um, Initially, we are going to see review evidence-based practice in this committee to find the inclusion and the exclusion criteria, as many of us just do not know who can we mobilize and who can we not, what is safe and what is not safe. But that starts with finding research, seeing what other hospitals are doing, getting evidence-based practice, and creating policies and protocols. Once we have that in place, we're going to need to address the goals with administration and funding, because we will be incurring additional costs to implement this goal initially. Like I said, in the long run, it will decrease costs, but to begin, we will have to increase these costs. We're going to have to hire or add on additional staff when we're going to work with these patients, some who may even be on ventilators, and some that might need 2 or 3 people to help them walk. We're going to need to buy special equipment that are able to help mobilize the patient, take off 50% of their weight or more, but to help them be in a vertical position versus a more horizontal in the bed. There are also equipment like cardiac chairs where patients can get pulled across and the bed goes into a chair-like function. I understand that there's already beds like this, but at least for me, when I get a change of environment, I do feel much better, and there I go back to the psychological effects of mobilization and being in that same position. Once these policies and procedures get hashed out with this initial goal, the rollout will require increased staff to help the program get started off correctly. And we are going to be able to provide extra staff for these patients and the staff so they don't feel like it's an additional pressure for something that they're going to have to do, or an increased task that they're going to have to do. Once it gets rolling, we will also create those disciplinary teams so that we may discuss with the nurses, with the respiratory therapists, the physical therapists, and the physicians what is working, what isn't working, and suggestions for it to get better. Nothing will derail a project quicker than staff that does not want to implement it, that has a negative attitude towards it. So if staff is included in the decisions, they have an ability to feel like they own the situation, and they are able to create an environment where they are happy with it and the patients are also happy, and help the program succeed. So with these disciplinary-based teams, we will also refer back to that initial unit-based team where we can relay all of our concerns and things are going to be improved. To evaluate the goals of this project, it's not going to be an immediate return on investment. We are not going to see immediate decrease in lengths of stay. It will be a process while the details are sorted out. But overall, we will see a decrease in patient stay in the ICU. We will see decreases in hospital-acquired infections or pressure ulcers because of the extra movement and the ambulation of these patients. Another way to review, to evaluate the progress is a system called current level of function and previous level of function, or CLOF and PLOF. Using CLOF and PLOF, we can see that their current level of function is a 1 is they're only able to stay in bed, and a 5 is they're able to walk greater than 50 feet. So if we see a CLOF of 1 prior to early ambulation, and they had a PLOF of 5, which is their previous, they were walking, then we know that these metrics, after implementing our early ambulation, hopefully will get better. If we have a PLOF, which is a pre-level of function of 5, hopefully we can keep their current level of function, or CLOF, at a 3 instead of down to a 1. We're also going to hope to see that the rates and lengths of stay for ventilated patients will have decreased. Lengths of stay for the critical care environments have also decreased. With these, if we can meet our goals, then we will be able to increase patient satisfaction and family satisfaction, because they see that we are performing innovative things that other hospitals they've been to may not have been performing as well. So that not only increases their satisfaction, but the reputation of our facility. And once the reputation of our facility increases, physicians in the community will want to send their patients to our units or our critical care environment, because they know that we are not only doing the bare minimum, but we are also actually proactive in the improvements of their patients. Thank you very much, and that is my presentation.